Welcome to Board Pearls. This is episode 4 of 4 of the Esophageal Motility chapter in the Esophageal Disorders module. Last episode covered the body that contracts too much on a normal IRP. This episode is the other way a body fails on a normal IRP, doing too little, ineffective motility, absent contractility, and scleroderma. And it closes on the one motility diagnosis you're required to distrust, outflow obstruction, where the IRP is elevated but peristalsis is still firing. You tell the weak body disorders apart not from the tracing alone, but from the tracing plus the LES pressure, so keep both numbers in hand as we go. Ineffective esophageal motility is the one you'll be tempted to overread, so keep its purpose in mind before its cutoffs. The pattern is a normal IRP with more than 70% of swallows ineffective, or at least half of them failed, where ineffective means a failed contraction with a DCI under 100, a weak one between 100 and 450, or a fragmented one, a break longer than 5 centimeters in the 20 mm isobaric contour. Hold those numbers loosely on purpose, because on their own they don't tell you the patient is sick. Plenty of people carry this tracing without symptoms. That's exactly why the criteria are deliberately strict, the pattern is common and the disease is not, so the threshold exists to keep you from overcalling it. What actually matters isn't whether the threshold is met, it's whether the finding is about to change a decision, and there's really only one decision it changes. Can this esophagus survive a fundoplication? Reason it mechanically, and you'll never forget it. A full Nissen wraps 360 degrees around the junction, and something has to push a bolus through that wrap, so a pump that's already weak is about to trade the patient's reflux for a lifetime of dysphagia. That's the entire reason you measured this. And you don't guess at reserve, you provoke it. With multiple rapid swallows, 5 quick wet swallows, a couple seconds apart, that should summon one strong post-swallow contraction beating the average of the singles. A strong one says the muscle was holding reserve and can handle a full wrap. A flat one has just predicted post-op dysphagia and sends you to a partial wrap instead, a toupee at 270 degrees, or a door at 180. Notice you never had to decide whether the ineffective motility was a real disease, only whether the pump could do the job you were about to ask of it. Absent contractility pushes the same logic to its limit. A normal IRP with every single swallow failed, each under a DCI of 100. The body tracing is now identical to type 1 achalasia, universal failed swallows, and once again the IRP is the divider that saves you. Normal here means the sphincter is innocent and the pump is the whole story. Elevated there means the sphincter is guilty. Because the pump can't be repaired, the reasoning turns outward, away from the esophagus and toward the systemic disease behind it. Scleroderma and the other connective tissue diseases lead the differential, but long-standing reflux, diabetes, amyloidosis, alcohol, myxedema, and multiple sclerosis all converge on this same endpoint, so the history goes hunting, Raynaud, skin tightening, sicca, neuropathy, alcohol, paraproteins, and the serologies follow, ANA, anti-centromere, anti-SCL70, and immunofixation when amyloid is on the table. And since you can't fix the motility, treatment aims entirely at the consequence, which is reflux. Scleroderma esophagus is where the second number, the LES, finally pays off, because scleroderma is defined by landing both hits at once, a failed pump and an open barrier together. Fibrosis replaces the smooth muscle of the distal 2/3 while sparing the striated upper third. And the very same process drops the resting LES below 10, so you get the worst possible combination, no wave to clear acid and no sphincter to hold it back. Trace the consequences forward, and they write themselves. Acid pouring across an open junction with nothing to sweep it away gives severe erosive esophagitis, peptic stricture, and Barrett in 5 to 35%, with adenocarcinoma staying rare despite that Barrett rate, though standard interval surveillance still applies. On manometry, the thing you're pattern matching to is precisely that pairing, absent or near-absent contractility, plus a hypotensive LES, and about 80% of scleroderma patients are hypocontractile at diagnosis, with many progressing to fully absent. That pairing is also your discriminator. It's what separates scleroderma from primary absent contractility, where the LES can be normal, and from achalasia, where the IRP is high, so the same failed swallow tracing resolves into 3 different diseases depending on the 2 numbers you already hold. The systemic conformation follows, ANA positive in over 90%, anti-centromere marking the limited cutaneous crest form, anti-SCL70, marking the diffuse form with more visceral involvement. Management flows straight from the mechanism. You can't fix the pump, so you attack the acid hard, twice daily PPI indefinitely, which controls symptoms in the great majority, plus head-of-bed elevation to borrow gravity at night when peristalsis is quietest, vonoprazan when reflux stays refractory, serial dilation for the strictures that keep coming, and a look at coexisting gastroparesis, which raises gastric residual and feeds the reflux from below. And here's the trap the whole section has been building toward, the pull to offer an anti-reflux operation, because the reflux looks like the entire problem. Resist it, and understand why. Fundoplication fails in scleroderma because the pump that has to push a bolus past the wrap has already failed, so a Nissen on absent peristalsis by severe dysphagia. Partial wraps get considered only in carefully selected patients, and magnetic sphincter augmentation and incisionless fundoplication have no role at all. The vignette writes itself once you see the logic. The woman with Raynaud, sclerodactyly, and bad reflux, whose manometry shows absent peristalsis and a low LES. And the answer is twice daily PPI, not a Nissen, for the same mechanical reason every time. That leaves the elevated IRP, and it's the one situation where you switch from diagnosing to distrusting. An IRP that's high but with peristalsis still firing behind it is a genuinely odd finding. The sphincter won't relax yet, the body hasn't surrendered the way it does in achalasia, and that's outflow obstruction at the junction. The single most useful instinct to bring is suspicion, because this is the one motility diagnosis where the pattern is more often a false alarm than a disease, which is exactly why its criteria are built as defenses. So read the three pieces not as a checklist, but as 3 ways of refusing to be fooled. The IRP has to stay elevated both supine and upright, because a supine-only elevation is usually not obstruction at all. It's an abdomen pressing on the sphincter while the patient lies flat. An elevation that shows up lying down but flags nearly everyone and confirms almost no one is worthless on its own, so requiring it to survive sitting up throws out the positional artifact. The upright cutoff is 12. The intrabolus pressure requirement, at least a fifth of swallows, is your positive evidence. The compartmentalized pressure a trapped bolus builds against a sphincter that won't open, and if it isn't there, nothing is actually being obstructed. And the preserved peristalsis is what told you you're here and not in achalasia in the first place. And the criteria go further and state the thing outright. This diagnosis, on manometry alone, is always inconclusive. To mean anything, it needs 3 things stacked together: the pattern, symptoms, and a confirmatory test. And that stacking is the single most important change here, because it clears the incidental cases out of the disease pool entirely. The 2 confirmatory tests each show the obstruction is real in a different currency. A timed barium swallow with a tablet shows a barium column still standing at 1, 2, and 5 minutes with a tablet that won't pass, and the functional lumen imaging probe shows the junction failing to open. Only with all 3 do you have a disease, rather than a finding. And even then, you owe the differential a walk, before you call it primary. Because the mimic list is long and the reasoning move is always the same, find the treatable imposter first, opioids top it again, raising the IRP and DCI, and shortening the latency so they can imitate obstruction, type 3, spasm, or jackhammer depending on which number leads, and an opioid history makes cessation the first test ahead of any myotomy. A paraesophageal hernia narrows the junction mechanically and shows on endoscopy and cross-sectional imaging. Eosinophilic esophagitis can stiffen the junction enough to raise the IRP, so biopsies belong in every unexplained case. Infiltrating cancer at the junction produces pseudoachalasia or obstruction, depending on how far it's spread, so the older patient losing weight fast earns endoscopic ultrasound and cross-sectional imaging. Obesity raises baseline IRP. Post-fundoplication anatomy reliably raises it, and some cases are simply an achalasia variant caught mid-evolution. Every one of those has to be considered and cleared before the label settles. So the workup runs as a sequence built to eliminate those imposters in order. Endoscopy first for a narrowing, a mass, hernia anatomy, retained food that hints at achalasia, and EOE biopsies, then cross-sectional imaging for extrinsic compression with endoscopic ultrasound added when cancer is a real concern, then a timed barium swallow for emptying, and the imaging probe for distensibility, with an opioid trial off the drug when the history fits, and a rapid drink challenge during the study itself, 200 milliliters through a straw, supporting the diagnosis when it drives the IRP over 12 with pressurization. Each step is aimed at a specific way of being wrong. The imaging probe deserves a moment, But stay with what it decides, not how the catheter is built. It sits across the junction and reports how widely the junction opens as it's distended, and the number to carry is the distensibility index, the narrowest cross-sectional area over the pressure inside, with the Dallas consensus line at 2.0. Normal opening is a junction reaching at least 16 millimeters wide, with the distensibility index of at least 2 at a 60 milliliter fill. Reduced opening is a diameter under 12 and an index under 2, and that reduced result is what supports obstruction, and supports achalasia in the patient whose IRP fell just short of the manometric line. 2.0 is the line to remember. The probe also reads the body's contractile response during distension, manometry, where normal is repetitive antegrade contractions, 6 plus or minus 3 per minute over at least 6 centimeters, and abnormal grades as absent, spastic, disordered, or diminished. Put opening and response together and you get a verdict. A junction that opens normally with a normal response makes a major motility disorder very unlikely, while a junction that won't open paired with a spastic or obstructive response supports achalasia or real obstruction. That verdict is exactly why the probe rescues the cases manometry can't settle, and each rescue is a reasoning shortcut worth holding. The patient with classic achalasia symptoms, whose supine IRP lands at 14, just under the cutoff, gets confirmed by a junction that won't open, so the borderline number stops being a dead end. The patient who meets manometric criteria for obstruction gets confirmed or dismissed by the same distensibility read, reduced opening confirming, normal opening sending them back to observation. A manometry that fails on artifact or intolerance gets salvaged by running the probe during the same endoscopy, no second visit. And the probe guides the myotomy itself during Poem and Heller, titrating to a normalized distensibility index that tracks better symptom outcomes. Treatment then falls out of the mechanism you proved, not the label you started with. When the body looks hypercontractile or spastic, and both the probe and the barium confirm real obstruction, you treat it as a type 3 achalasia variant with a longer Poem myotomy. When peristalsis is normal or weak and symptoms are mild, you observe with a PPI and dietary change, holding botulinum toxin or pneumatic dilation for disabling symptoms. Mechanical causes get treated for the cause, and opioid-driven obstruction resolves with cessation, or, if that's not feasible, gets managed symptomatically rather than with a procedure. In every branch, the treatment is downstream of the mechanism, which is downstream of the two numbers. So here's the whole weak body and obstruction picture, short. On a normal IRP, the body that does too little sorts by how much peristalsis is gone and what the LES is doing. Ineffective motility raises the single question of whether a fundoplication is safe. Absent contractility sends you hunting for the systemic disease behind it, and a weak pump paired with a weak LES is scleroderma, which means aggressive PPI rather than surgery. And outflow obstruction is the separate case, the one diagnosis you're required to distrust until symptoms and a confirmatory test prove it real, with the imaging probe and timed barium doing the proving and rescuing the borderline achalasia that just missed the line. Every criterion in this whole chapter was only ever a way of answering two questions: what is the sphincter doing and what is the body doing? That hands us off to Chapter 3. The reflux that scleroderma drives is the severe end of a disease that starts as a barrier failure long before it becomes an acid problem. The OLEG grading on EGD stratifies treatment intensity and Barrett risk, with PPI timing and vonoprazan as the stronger option when acid suppression needs to go further. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 404 of Chapter 2, and I'll see you in the next one.